Hello, everyone. Can you hear me well? Thank you all for joining, all our professors and colleagues. Thank you all for joining today. As you all know, this is a webinar hosted by the Neurology Department at Misr Radiology Center. I just want to confirm that you can hear me well, right? Yeah, it's on. Okay. This is a webinar hosted by the Neurology Department at Ain Shams University in collaboration with Misr Radiology Center. We will be discussing PET MRI neurological applications. This is the first PET MRI to be installed in Africa and the Middle East. It has been installed in MRC's state-of-the-art New Cairo branch. MRC has already done 10 plus neurological cases of PET MRI, and we'll definitely shed light on some of these cases today. I'm very pleased to present to you today Dr. Hani Arif, Head of Neurology Department at Ain Shams University, and Dr. Yasser Abdelazim, Head of MRI Department at Misr Radiology Center. We will be starting by a discussion between the two renowned professors and a presentation by Dr. Yasser Abdelazim over the applications of the neurology of the PET MRI machine. And then we can open the floor to questions. By the time the questions come, please feel free to type your question in the chat and I'll make sure I'll read it out loud, or just mention that you have a question and I'll call the names in a sequential order. Please make sure that you are on mute and your cameras are disabled at all times. I'll be able to control that as well. Dr. Hani, you can take over from here.
Thank you, Dr. Doha, for this kind presentation. It's my pleasure to moderate this webinar with my dear colleague, Dr. Yasser Abdelazim. Dr. Yasser, of course, he's well-known neuroradiologist, specialized in MRI and professor of neurology at Ain Shams University, and he's my dear colleague since we were residents, actually, and we did a lot of work together in establishing many protocols. We hope that this new innovative technique also will help us in doing new research and in also understanding the neurological disorders much more. It's a great honor that we are having this machine for the first time in the Middle East and Africa. Of course, maybe we are a bit aware of the routine PET scan, but maybe this is the first time that we are dealing with the PET MRI. So it's very important to understand how this machine is adding to the neurology field and the different applications of this technique. And probably, of course, this will help us in many aspects, either in the management of our patients or in the research field. So I will give now the mic to my dear colleague, Dr. Yasser. Dr. Yasser, the floor is yours.
Bismillahirrahmanirrahim. Can you hear me now?
Yes.
Okay. Bismillahirrahmanirrahim. Thank you all for joining us for this webinar, and I will be talking today about the neurological applications of PET MRI, which is the most new modality or hybrid modality in the arena. This is on the occasion that we have had the first and only PET MR machine in our newest branch in Tajammu. And we already started doing PET MR studies for different applications, including neurological applications, which is my domain of interest. And I would like to thank very much my dear colleague and old friend, Professor Dr. Hani Arif, Head of Neurology Department at Shams University, for hosting this meeting together with the honorable members of his department and other neurologists and neurosurgeons from across the country. Just one thing before I start, that we will be recording this audio or this webinar. Right, Doha, we are recording it now?
Yes, it's being recorded.
Okay, and then we will send it to you all and to whoever whose circumstances didn't permit him to attend with us. Okay, so PET imaging alone suffers from limited spatial resolution, low sensitivity, and scatter correction, and needs scatter correction. So it is best to be fused, or the better word is to be a hybrid part of either CT or MRI. Now, for the neurological applications, we all know that MRI is the mainstay because of all its capabilities doing pre and post contrast, diffusion, perfusion, fMRI, and MR spectroscopy. So it's the most suited for as a hybrid technique for PET MRI. And why do I say hybrid? Because the MRI, while it is done, PET data is acquired simultaneously. So you don't have any causal registration mistakes, because the patient is lying down, having his MRI, and simultaneously and at the same time PET data is collected. So you get this hybrid thing, and it's also best for attenuation correction. Now, the PET MRI was feasible in 2007, and the first PET MR machine came into the arena in 2010, and here in Egypt, we started working in 2020. This is the machine itself, our actual machine at our news branch. And of course, it's like any other MR machine, and the patient lies down, and this is the head coil for the neurological applications, and he's quite comfortable with it. And the PET detectors are in the gantry over here while he's put in the magnet. This is a more romantic view of the same machine in a better lighting for comforting the patient. Okay, what's my outline? What are the main neurological PET MR applications? Now, I would say that now PET MR all over the world, especially in USA and the Western countries, has the three main applications are brain tumors, epilepsy, neurocognitive impairment with dementia. So these are the majority of patients coming to do PET MRI all over the world fall into these three categories. And epilepsy also, especially for those who will have epilepsy surgery. And of course, all of us know the neurocognitive disorders and dementia, very important topic in the Western countries, but we have a very active team for neurocognitive and dementia issues at Ain Shams University, led by very smart, nice young guys under the leadership of Dr. Hani Arif. The other three minor applications, they are not minor regarding the disease prevalence, but minor for PET MR applications, are multiple sclerosis, autoimmune encephalitis, and cerebral vascular stroke, and particularly vessel wall imaging. And being minor, they are a very fertile aspect for future research. So as we are all, or most of us are academics, so and also I know the neurology department is having a heavy academic activity, and in publications and in studies and trials, etc. So this is a very fertile part where we can further study by PET MRI cases of MS, of encephalitis, and of stroke, especially vessel wall imaging and subacute stroke conditions. Now, starting by brain tumors, we have PET MRI can be used for tumor grading and differential diagnosis. Tumor grading is done by all our techniques. We have very big experience by this, and every patient who gets a PET MRI gets all these simultaneously. So we do the conventional pre and post contrast, perfusion, diffusion, spectroscopy, besides the PET. And this is to distinguish high grade from low grade gliomas. And even now with the 2016 WHO brain tumor classification, we can say whether the tumor is IDH mutant or IDH wild type, or does it have 19q co-deletion, all these things that are very important now for the choice of type of therapy and the follow-up and the longevity of his life, etc. Now, why this is also important to have a PET MR study in particular? This is in the second paragraph, because even high-grade, some high-grade tumors may not always have enhancing parts. So, because they might not be enhancing and might be of the wild type, so PET detects the metabolic activity, as I'm going to show you, which guides biopsy and changes the grading. Also, we can delineate by this the highest grade for the therapy, the targeted therapy, the biopsy, detect transformation from low grade to high grade. What do we use with PET? We all know about PET-CT, and the main tracer, of course, with PET-CT is 18F Fdg. It's a fluorine-based tracer, and it's the same. We use it with our PET-MR studies in all the applications I have mentioned. However, certain applications have other group of tracers more specific. So for instance, since we are now in the brain tumor category, there is 18F DOPA, 18F meso, 18F FET, all these are fluorine. And then we have a gallium-based tracer, which we have recently done. And I am, as a surprise for all of you, or as a bonus, I'm going to show you a case we just did yesterday using Gallium Pcma. Gallium Pcma, for those of you who might have heard about it, is mainly used for prostate cancer evaluation. But there is an Indian group, very active, who used it for brain tumor, especially the high grades, to differentiate recurrent tumor from post-therapy changes. And so we went on their footsteps and had a very nice result, as I'm going to show you. So these are more specific for brain tumors because FDG is uptaken by the normal brain tissue itself. So the difference in uptake between the high-grade tumor and the background might not be as good as the other more specific tracers. This is a case using F-DOPA, and here you can see on the flare sequence, we have a tumor right front to parietal with mass effect. On the post-contrast series, you do not see that much amount of enhancement. It's not that enhancing. Maybe if you, in retrospect, there is faint patchy enhancement over here. Now, look on the PET study. This is the original PET data, or what we call the Q-clear or the MAC. And this is the hybrid study where the PET is superimposed on the MRI. And look at how much uptake is in this inner part of the tumor. So you might have called it just a low grade by the flare and T1, okay? But certainly with PET, first of all, you would say it's a high-grade tumor. Second, this is the best site for biopsy and for any therapy you are going to do. This is the ADC and the color map for it, derived from diffusion data. Now, the second application besides the initial grading and the guidance for biopsy and therapy is post-therapy follow-up, differentiating residual or recurrent tumor from post-therapy changes. Of course, we do all our routine thing. We do the contrast MRI, pre and post-contrast MRI with diffusion. This is the routine which is asked for by all the neurosurgeons and neuro-oncologists. And then in the second step, if things are not that clear, we can do spectroscopy with perfusion to increase our sensitivity and specificity. But also by this, sometimes we do not have all the answer, like the latest case, and some cases which we did by PET MRI. So now PET MRI comes into the arena because it offers a completely different set of information, which is the metabolic information, which when added to the conventional and functional information from these above, gives us a much better sensitivity and specificity, as I'm going to show. So here is a case from the recent literature where T1 post-contrast shows an enhancing lesion after being treated by combined therapy, i.e. radiotherapy and chemodal for the high-grade malignancies. And then look at the PET here. Let's first look at the perfusion. The perfusion also is not that typical for having residual or recurrent tumor, as well as the ADC. Also the spectroscopy to me, and I do a lot of spectroscopy, is somewhat equivocal, but on the PET study, there is a high uptake over here, denoting that there is a recurrent tumor or residual tumor in this post-therapy case. Another case where there is a vivid uptake over here at the corpus callosum, and here everything is going together: enhancement, PET, high uptake, hyperperfusion, low ADC, very high choline peak. Now, let me show you the case where we used a more specific tracer for the purpose of differentiating post-therapy from tumor. We had a 65-year-old male with pathological proven high-grade glioma coming for assessment. We did for him everything we can, but still we could not 100% be sure whether what we are seeing are post-therapy, especially post-radiation necrosis, or viable tumor tissue. Now, this is the flare showing a moderate-sized left frontal lesion, and this is the T1 pre-contrast heterogeneous lesion with hemorrhagic components. And here we have on the post-contrast T1 enhancing bits from the tumor, larger one, more medially or more at the inner aspect, and less enhancing at the outer aspect. We were not sure what is tumor, what is post-therapy. We also did diffusion imaging with ADC, and here there is a mixed diffusion behavior. Some parts have low ADC of high cell packing, some have not, and this is the color ADC map. So it's really difficult. Some cases are difficult. You are not sure. Nothing is striking to say the proper answer. Now we went for the Gallium Pcma PET, and here we have the initial PET data without any superimposed MR. Here is the T1 post-contrast, and here are the hybrid or fused images where the PET data is put over the MR data. And look at this part having a very high PSMA uptake, especially the innermost portion with the red color. This is a very much matching or going with viable high-grade glioma. And also, I'm going to show it to you in the various planes. Here is in the coronal plane, also the high uptake over here at the inner aspect, very much beautifully shown by these color maps and the superimposition. And if there is any doubt in the mind of the oncologist, this is the site of stereotactic biopsy, this part, but it's very much suggestive of residual or recurrent high-grade tumor, while the outer parts, they have some uptake, but not that much as this portion. So while on the post-contrast series, you will not be able to differentiate this very much, here you can say to a great confidence which part is viable tumor and which is not. Also on the sagittals, the same thing. So it's in the inner posterior aspect of the lesion, which is the most malignant. So I hope by these cases, I have shown you that simultaneous PET and MRI can be used for glioma grading, especially differentiating high grade from low grade, extent of the tumor, determining the non-enhancing tumor margins, follow up, as I have shown you, differentiating radiation necrosis and pseudoprogression, which are both therapy changes from residual or recurrent high-grade glioma. Now, a very short hint about metastatic disease. I'm not going to show you a case. We have so many cases because, of course, metastatic workup is done as a whole body MR study, but also brain metastases are can be very much evaluated by PET MR using FDG, and they show a very high uptake and can be incorporated, as I said, among the spectrum of a whole body MR study. So you see the metastatic load and nodal load all over the body, as well as in the brain in one-stop shop. You do not need to do MR brain alone and then PET CT alone. You can do this all in one stop. And also an important tracer is now gallium dotatate. Gallium dotatate, and we have an experience with this tracer. It's also gallium-based like gallium Pcma. This is in particular quite useful in distinguishing pachymeningeal metastatic deposit from meningioma. Why? Because dotatate is heavily and highly uptaken by meningioma, but not by metastasis. And this is very important in these difficult cases of breast cancer, where you have this intracranial extraaxial lesion, and you don't know, is it a meningioma in this lady or is it a pachymeningeal deposit? And the difference is, of course, very, very important to distinguish this. So we can use this specific tracer for this purpose. To end up the tumor thing, so somebody might ask, so are you going to do all these things? What's the benefit of doing conventional spectroperfusion and then even PET MR? Now, this study in 2017 in the American Journal of Neuroradiology has shown that when you combine PET MR to what I mentioned before, like MR with contrast, with diffusion, and with spectroscopy and perfusion, you get a higher ROC curve, which is exceeds all the others together. So PET MR plus this is the best, okay? And that's exactly what we are doing. We are doing all these conventional and functional data and adding PET to them, and this produces the highest ROC curve and the highest performance as such. Now, the second part about epilepsy, first of all, of course, for the non-neurologists in the meeting, I just wanted to highlight that epilepsy is the chronic condition characterized by seizures, while a seizure is a single epileptic attack. So that's to make things clear for all of us. Epilepsy can be assessed either ictally, but this is usually by SPECT, which is a high-end type of nuclear medicine, and this has to be done during the seizure activity, which is very complex and different to perform, especially in private centers and even in hospitals. The beauty of PET MRI is that you can do this interictally. You can assess epilepsy interictally. And of course, when you assess it interictally, this means you are looking for now for hypometabolism, while in the ictal stage, it is hypermetabolism. So here we are using the Fdg tracer to see the hypometabolic parts, whether these are regarding mesial temporal sclerosis or focal cortical dysplasia or tuberous sclerosis complex cases. The combination of Fdg and MRI, high-end MR epilepsy protocol, is best suited for preparation for epilepsy surgery. Why? Because you might see something on MRI, which is an epileptic focus, but the zone around it is hypometabolic and it's also causing epilepsy. So PET MR gives you the full study of the case in order to do a proper surgery, not missing any part which is hypometabolic and not seen by the conventional MRI. Also, it's proven that can everybody please mute his microphone for the sake of the others? Thank you very much. The interictal hypometabolic lesions detected in PET MRI are highly probable to represent epileptogenic foci, even in MR negative cases or with multiple structural abnormalities. And I'm going to show you how sometimes we have a negative high-end MRI, but there is metabolic abnormality on the PET study. So in this, this is again to say that there are MR negative studies where PET MRI serves the best. Also, we can add, but maybe not in the same setting, doing functional MRI as a preoperative evaluation for epilepsy surgery in order to determine the eloquent language and memory areas so that they are not hurt during the epilepsy surgery. So this is another benefit from PET MRI and then combined with functional MRI in the same setting or in another setting. Let's look at some cases. So here by the conventional MRI on this coronal flare, we have a left-sided mesial temporal sclerosis, very obvious to all of us, small hippocampus, abnormal high signal on flare. Okay, but on the PET, there is also hypometabolism here compared to the other side. Yet what's also very important is that this zone of the temporal lobe is also hypometabolic compared to the contralateral side. And actually, anatomy-wise, and also you can see, if you go back here, you can see reduced sulcation and cortical thickening. Actually, if you are somewhat more deep in epilepsy, anatomically wise, this is the entorhinal cortex, and so this part is very important. It's actually said that it's the most important factor in producing epileptic attacks, and the outer part is the perirhinal cortex, also as well having a crucial role in epilepsy. So by PET, you not only demonstrated the hypometabolism of the hippocampus, but also of the entorhinal and perirhinal cortex, and this is very important as preparation for epilepsy surgery. So I think the epilepsy surgeon might be, I don't want to get into this, but certainly this type of information is much more important and crucial to him than just the information provided by the conventional MR alone. Now here we have a case where if you look at this conventional high resolution MRI, at least to me, I cannot find anything wrong in this T1 axial of the brain, but look at the PET, how you can see very well the hypometabolism at this left temporal region compared to the contralateral side. And here is the fused or the hybrid data. Now you can see the hypometabolism over here compared to the other side. So this is negative conventional MR, positive PET MR, and the patient, once you find the lesion, and as my also dear friend and long-standing colleague, Dr. Ashraf Ghubashi, once told me a long time ago that finding an epileptic focus or something structural abnormality in an epileptic patient is the best thing, instead of saying we don't have anything, because now he has a chance to have surgery and to be cured. Another case here where conventional MR is unremarkable and PET MR shows hypometabolism, which is also corresponding to arterial spin labeling, which is a type of non-contrast perfusion, showing as well hypoperfusion status, but the PET MR better and more demonstrates the zone of metabolic abnormality. So this is a case where we have negative MR, but positive PET and positive arterial spin labeling. And in our protocol, we actually do for all our cases arterial spin labeling technique besides high-end conventional MR and of course the PET MR. And this is the surgery and the histopathology revealed focal cortical dysplasia type 1B, which is the common type. Now, this is another similar case, but different. This is focal cortical dysplasia type 3A on histopathology, also negative MRI. But look here, also the arterial spin labeling is negative. You cannot really say that you have difference in perfusion that confidently. However, by the PET, very nicely, you can see the hypometabolism here at the left temporal region. So normal MR, normal arterial spin labeling, but abnormal PET. And I apologize for the type machine. It was type 3A actually, not type 2. It's type 3A. Okay. Not only we do this by our eyeballing or our qualitative assessment, we have a quantitative way, like the eye cortex present on the PET MR machine, and I have used it maybe a couple 3 times. And what it does is that it gives you the Z-score for the different brain regions on each side. And the Z-score is a measure of how deviated you are. And here at the left hemisphere, there is a remarkable deviation from normal controls regarding left occipital and left temporal regions. And it is quite clear by these small figures. Let me just go to the high numbers, like the cingulate on the left side, like the superior parietal on the left side, all these, occipital, of course, on the left side, all these numbers that have like 2 or 3, etc., are all quite abnormal on the left compared to the right. Look, for instance, for the occipital, on the right, they score 0.51. So not that deviated from normal, but on the left, minus 3.45, remarkable deviation from normal. And this is interpreted as these synthetic color maps. So you confirm what you have seen by your qualitative eyeballing. Actually, I have just finished attending virtual online, the American Society of Neuroradiology meeting, which was done online during the past week. And there was a very beautiful PET MR lecture, and I have borrowed these slides from them, but please don't tell them, okay, or tell them, whatever. Anyway, this is a case where there is this coronal T1 weighted images and very difficult to see anything, at least I couldn't see. And the clinician who showed, or the PET MR radiologist who showed it, they did not call anything abnormal. Yet when they went to the PET MR study, look here, there is a very evident hypometabolism right occipitally compared to the normal right side. Okay, so this was a case of focal cortical dysplasia, and the patient did well after surgery. Another case, but the answer is given right away. Initially, they were thinking of this part to have maybe small cortical thickening, but they didn't suspect at all this frontal region. Okay, now on the PET, this had normal metabolism, but the left frontal region had a zone of more hypometabolism compared to the right. Very evident here. This is hypo compared to the contralateral side. So this was a focal cortical dysplasia type 2, and the patient also did well after epilepsy surgery. Third and last case I borrowed from them. We have a T2 weighted, and we have an arterial spin labeling, but not colored. And also over here on the T2 weighted and on the arterial spin labeling, nothing that strikes your eyes as an abnormality. However, when they went to the PET and even the T1 axial, This is the T2 we see in the arterial spin labeling, and here the T1. And look how beautifully that is the original PET data and the PET MR when they are fused together. And look here, especially on this initial PET data, there is hypometabolism at the left parietal region over here, and corresponded to, in retrospect, they now thought there is a presumed focal cortical dysplasia, and it was pathologically proven. So this is also a slide I borrowed from them, from that lecture, and what he said at the end for all of us, PET MRI, especially in pediatric epilepsy, is it now the time for it? And yes, and everybody loves it, and the children love it because, and the parents love it because with PET MRI you do not have ionizing radiation, and it gives you answers that you cannot get by any other means. So to help these kids and young adults and anybody to detect the epileptic focus and have a way of treating him. Okay, moving to the third major application, neurocognitive impairment and dementia. And also for the non-neurologists in the audience, what do we mean by neurocognitive impairment? It is decline in one or more of the following 6 cognitive functions: complex attention, executive functions, learning and memory, language capabilities, social cognition. I'm afraid social cognition, now that we are all at home, we will have a decline in social cognition, but hopefully not, we will meet each other again. And then perceptual motor function. So if you have a decline in one of these or in more than one of them, this means there is neurocognitive impairment. Very busy slide, but basically it says that PET MRI is now the modality of choice in assessing all these neurodegenerative disorders and dementias. And what I have to add, and also this says what are we using as tracers. Fdg is used as the main tracer, but there are also other tracers in the arena like amyloid plaque tracers and tau tracers, which are more specific tracers, especially for Alzheimer's disease. And this is a very important statement, which says each type of dementia has its own fingerprint on PET MRI, and that's what I'm going to show you. And when we talk about Alzheimer's disease and then mild cognitive impairment, what we would really like is not to assess patient when he has Alzheimer's disease, especially in the late stages. We want to pick up the early cases, especially when there is mild cognitive impairment at the beginning, or there is a family history or whatever, so that when I was thinking of doing PET MRI, that anybody who is worried that he's starting to forget more or whatever, so he's worried about himself that he might be having Alzheimer or one of the other dementias, if he does a PET MR and it's negative, then he is really happy. It's the same thing like we all do for our cardiac condition and our vessels, carotids, etc. You do not want to go when you are really sick. You want to go to be comforted about it. Okay, so this, and then also you pay for the study from your own money, because when you have dementia, maybe nobody will care about doing PET MRI for you. We are not like the Western countries where they have all these studies and trials and recruitments, etc. Okay, so PET MRI can very well differentiate Alzheimer's disease from frontotemporal lobar dementia, FTLD, and dementia with Lewy body, which are the 3 measures in the dementia arena, with Alzheimer maybe considering about 60 to 80% of cases. And I'm going to show you, we do this mainly by FDG, and then I'm going to show you how amyloid plaque and tau can also help. Tau tracers, amyloid plaques, of course, are taken by the amyloid parts which increase in Alzheimer, and tau tracers assess the neurofibrillary tangles in cases of Alzheimer's disease. So Alzheimer's disease, hypometabolism on PET at the temporal lobes, sometimes the frontal lobes, the posterior cingulum gyrus, and the precuneus. So this triad is the characteristic one for the Alzheimer's disease, especially the posterior cingulum. Unlike most people think only of the temporal lobes, no, the posterior cingulum to me is more important, and I'm going to show you why. Here is a case of Alzheimer's disease. Let's look at the comparison with the controls. This here, this is a Z-score map, and you can see how there is this is not uptake by the hypometabolism, but this is the Z-score showing the remarkable affection regarding the posterior cingulum and the precuneus and the temporal lobe compared to normal controls. And here is the hypometabolism in this patient. This is the conventional, etc. So this shows you the fingerprint of Alzheimer by PET-MR using FDG. Another case here, we see that there is a good uptake in a normal subject. And look here, the posterior cingulum and the precuneus having very nice uptake. So this is the normal pattern. Now, if you go to Alzheimer, look, all the red that you have seen has disappeared now. Very low uptake. Only these parts retain their uptake. And so cortical hypometabolism, and especially in the posterior cingulum and the precuneus. Another case, conventional MR, you do not really see anything of importance, but when you go to the PET on the sagittal, here the precuneus is affected. The precuneus is affected. Fingerprint pattern for Alzheimer. And again, here the posterior cingulum and precuneus and the adjoining occipital lobes and parts of the frontal lobes in the same patient. And this is the Z-score confirming this data. Look at how the cingulum is affected, the precuneus is affected, the temporal lobe is affected, and this purple color is the high Z-score, high deviation from age-matched normal controls. And this is just to show you that we also combine this, we do for all our dementia patients also susceptibility weighted imaging, which shows you the remarkable deposition and presence of these small amyloid angiopathies, particularly in these peripheral subcortical locations, very characteristic for Alzheimer's disease. But also characteristic for Alzheimer's disease, you never see them infratentorial. I mean, you do not see them. Never is maybe a hard word, but very unlikely to see them infratentorial in the cerebellum. Okay. Now going to the amyloid plaque tracer. Here, the tracer has abnormal increase. With FDG, there was a hypometabolic status. With amyloid, because amyloid increases in case of Alzheimer's, so now we look at an increase in the tracer uptake. And there is always sparing of the cerebellar hemispheres. This is a very important denominator in these cases. And by this high abnormal uptake, we get poor differentiation of gray-white matter, as I'm going to show you. So let's look here. This is a normal subject, had amyloid study, PET-MR, this is PET-MR amyloid study given in black and white. The white matter is the one that gets the high uptake of the amyloid normally. Normally, white matter gets this and becomes white, and the cortical gray matter does not take the amyloid, so remains dark like this. So this is the normal pattern. And also infratentorially, there is high uptake on the cerebellum, normal uptake in the cerebellar gray matter, okay? So memorize with me the normal pattern, and now look at this case of Alzheimer's disease. Here, the cortical gray matter has uptaken the tracer, and the white matter normally takes the tracer. So you get this poor or no white gray matter differentiation, loss of normal gray matter differentiation. Okay, in this Alzheimer case. And then this is the cerebellum. You see that in the cerebellum there is the uptake is normal and preserved gray-white matter differentiation, preserved in the cerebellum. Always the cerebellum, and you know that your study is right by showing a normal cerebellum in these cases. Okay, the last tracer in the arena now for Alzheimer and various dementias, but Alzheimer in particular, Alzheimer in particular is the tau tracer, which, as I said, it's mainly uptaken by the affected neurofibrillary tangles in the brain. Also, there is an abnormal uptake and sparing of the cerebellum. Let's look at a case. This is a normal patient, normal control. There is no high uptake in the brain. However, in the Alzheimer case, look at this part right occipitally. There is a high uptake in this case of Alzheimer disease, and especially focally at this part by the tau tracer. And then we can do quantitative assessment as the one I've shown you for epilepsy. You can also do them for dementia. And actually the eye cortex has been initially proposed for the cases of dementia. And you can also look at the Z-score, as I said, and produce these quantitative assessments. And so not only doing it by eyeballing, but also quantitatively. Frontotemporal dementia, we use the Fdg, and the pattern of it is that there is reduced uptake at frontal and temporal regions, sparing posterior cingulate and precuneus, and that's how you differentiate from Alzheimer. So please, for the radiologist in the audience, do not rely differentiating Alzheimer from frontotemporal on temporal and frontal parts, because in both diseases, they can be affected by atrophy and by reduced uptake. But rely more on the posterior cingulate and precuneus, which are spared in FTD and affected in cases of Alzheimer disease. And of course, Dr. Hani Arif would remember that we used to do resting function MR in these cases, and we used to discuss that not even for us who do more heavy and more in-depth studying of such cases, that even this has subtypes, you know, like some things that has to do with speech, etc. So there are subtypes for FTDT, but I'm not going to go into it in this study, because this has more complex assessment. So let's do our PET-MR part. And looking at this case, we have remarkable atrophy temporally over here. You might think it's a case of Alzheimer. However, you also have this frontal affection. So now you are a bit deviated from it being Alzheimer. And then look on the pattern of the uptake. Very nice uptake posteriorly. So the cingulum and the precuneus are not affected, but the affection is frontotemporal. So this is the FTD type frontotemporal lobar degeneration pattern of using PET-MR. And again, we can see it on the coronal plane, nothing in the posterior aspects, but all of it is happening temporally and frontally by the reduced uptake. Okay, now last but not least, Lewy body dementia, also using FDG. What is the pattern? It has certain similarities to the Alzheimer, but usually the reduced tracer uptake is in the occipital lobes and the precuneus. However, you see, I told you the precuneus is affected in Alzheimer, but here there is sparing of posterior cingulum. Sparing of posterior cingulum, unlike in Alzheimer, and I have a very nice slides for this. Look at the conventional MR, some atrophy over here posteriorly, and also in the axial occipital, bilateral occipital lobe atrophy. And then look over here. Okay, the precuneus is affected, but not the posterior cingulum. Precuneus affected, but sparing of the posterior cingulum. And this is a very nice representation. And this has been described by the people in like Patel, etc., and that this is called the cingulate gyrus island. Okay, so it's a singular gyrus island because it is an island of heavy uptake, while the occipital lobes and the precuneus have no uptake. So no uptake occipitally and precuneus, normal uptake in the posterior cingulum, looks like an island over here, characteristic pattern for Lewy body dementia. And also proven by the Z-score, sparing of the posterior cingulum and the abnormal uptake in the precuneus and the occipital lobes. Okay, so now I have finished the 3 big applications. Now to the more minor applications, but this doesn't mean they are minor diseases. And I know that in Ain Shams University, there is very heavy research regarding stroke and regarding MS, multiple sclerosis. So I'm going to tackle these issues. Stroke or cerebrovascular stroke. Now, what can PET-MR do? Of course, PET-MR can give you a very good diffusion-perfusion mismatch data, like the one you do in the acute stroke cases now by the rapid software on CT and by the MR stroke protocol and all these things and all these trials that we might spend one day discussing them. So PET-MR can do the same, but it's not applicable. Who will do PET-MR in the acute stroke patient? Okay, so even though it can do this perfusion-diffusion mismatch pattern, but people have decided to reserve it for the more subacute and chronic ischemic and infarct conditions, okay? And this is a busy slide, but basically it says that it is better to be used or preferable to be used in subacute and chronic stages. And here is a puzzling case where they did for it some arterial spin labeling and also PET, and the results are coinciding together. So you have this hypometabolic zone on PET corresponding to the hypoperfused part on arterial spin labeling. So PET can show you also the extent of the affection, and in such stroke cases and in cases with hypoperfusion. And because I don't want to go into this time, there are like stroke mimics, like these migrainous conditions and things with auras, etc. All these type of things that are difficult to diagnose, and they are mimics of stroke, and they don't respond to the usual drugs for ischemic conditions. So all these group of patients can be studied by PET-MR. An important application as well is that of vessel wall imaging, and we are doing heavy work with this. And actually, I want to thank the neurology department and Dr. Hani Arif and Dr. Hani Zaki for encouraging us with their referrals of vessel wall imaging cases. And even we had, believe it or not, that the first candidate whom we supervised was actually from the Department of Neurology, not from Radiology. And he did a very nice thesis about vessel wall imaging. So what does PET-MR add? PET-MR can add that it shows you and confirms the vessel wall inflammation. The vessel wall inflammation, which shows a high uptake on PET. And this is confirmatory that this plaque is vulnerable and dangerous and can cause embolic events and can go ahead and become more dangerous with more occlusion, etc. So this is the main value of PET. And look, in this case, this is the vessel wall imaging. I don't want to get in it, but you can see that compared to the right side, the carotid here on the right compared to the left, in the various sequences we do vessel wall imaging for, there is narrowing and there is abnormal enhancement, etc. And then on the PET data, whether the initial PET or the fused PET data, you have high uptake in the plaque, very high, due to the inflammatory condition. So this is, here we have an inflammatory process in this plaque and making it even a more dangerous plaque. And the same applies here in the origins of both internal carotids. I think all of you, the vessel imaging would show the narrowing, but the more inflamed is on the left side as shown by the PET data. So PET data, the higher the uptake, the more the inflammation regarding this plaque. And this especially has been reported in literature, especially important in non-stenotic carotid lesions, because the study basically said that in such non-stenotic carotid plaques, when you have a high PET uptake, this means that it is more dangerous and more vulnerable and more likely to cause a disease or damage, and more likely to cause more stenosis and more hypoperfusion of the part it's perfusing. So it's better to catch this in advance. Now, for multiple sclerosis, PET and MR are doing, MR, of course, is the standard of reference by all the techniques and all the things we do in various multiple sclerosis cases, but PET gives us more insight into the pathogenesis, clinical relevance, and especially therapy responsiveness, and all this can lead to more accurate and better triaging of the cases and better understanding of what's going on. And of course, in the neurology department, you know that this has been reflected in these many drugs that you now have to treat these cases. When, you know, like 10 years ago or whatever, everybody thought of MS that steroids or interferons. Now there is a whole list of new drugs and for different purposes. And PET-MR can certainly help in this triaging. What are the tracers? The ones we talked about. We can use the Fdg Tracer, but it's somewhat not specific, but can be used and shows you whether you have high uptake or low uptake in the plaque. And then the amyloid plaque tracer. Remember, the amyloid plaque tracer is the same one, fluorobatir is just one of them, which we used for Alzheimer's disease. It's the same tracer, which is normally uptaken by the white matter. So what would you expect in a case of MS? What I would expect without thinking that it will not be normally uptaken by, of course, the plaque, and more so by the normal appearing white matter. So now if you want to see really the disease load and burden, you give the myeloid plaque, it is uptaken by normal white matter and not uptaken by the abnormal white matter. And you can do many quantifications to assess the lesion load, and also you can assess the gray matter simultaneously. This is a case using Fdg, and this is the fused PET, and you can see that there is metabolism of these plaques with this heavy load, and this is the corresponding original PET data. So you can see this, and you can pick up that there is also a hypometabolic status of the normal appearing white matter by this Fdg, and you can do many quantitative assessments by it. Another case also showing the low uptake in the plaques and in the surrounding normal white matter. And this is a case by the amyloid tracer. And remember, I said that here we have a higher uptake in the plaque because normally there is uptake by the white matter, okay? But on the contrary, there is uptake by the normal white matter, but the plaque itself is of low metabolic activity because it cannot take this amyloid tracer. And then you can assess not only the plaque, also the surrounding white matter, which might appear normal, but if it does not take the amyloid tracer, then it is also abnormal white matter by the metabolic criteria. And this can be interpreted, as I said, into quantitative assessments. And here also using the Z-score maps, this is a healthy control, and look at this using the Z-score, how much disease burden that this patient have, because now we are calculating exactly the deviation from the normal control. And all these parts are, to variable extents, are affected parts, and you can have numbers and figures and which can help you in follow-up and in drug trials. Okay, this is a busy slide, so for the sake of time, just to mention that they have been using it to assess remyelination, especially after some of the new drugs like this one. I cannot even spell it, and I'm afraid to spell it in front of you, so I'm just going to point at it. And so again, it can guide better understanding and better development and better assessment of these cases, because the more you have knowledge by various such techniques and the more you understand the underlying factors and the more you can triage your patients into different categories. Last but not least, a small part about autoimmune encephalitis. And why autoimmune encephalitis? Because the normal encephalitis, or the more common encephalitis like viral or bacterial, these are assessed by MRI, and these are usually urgent cases. You cannot wait for a PET MR study scheduled and we wait for the tracer. Okay, so researchers for encephalitis using PET MR have concentrated on autoimmune encephalitis because these are usually troublesome cases and there is a lot of differential and difficulty in diagnosing them. And even by our MR criteria, we find difficulty in saying whether the temporal lobe and the surrounding has abnormal signal, or this is me imagining, or this is artifact, or whatever. Anyway, in the cases of autoimmune encephalitis, using FDG PET, you have avid uptake and hypermetabolism as opposed to normal brain parenchyma. Let me show you some cases. Okay, this is here a case. You are equivocal on flare, nothing on T1 post-contrast, but look how beautifully the PET MR has delineated this bilateral but more right-sided affection by very high uptake, and not only, and also extending to parietal regions and basal ganglia, etc. So this is a case proven to be autoimmune encephalitis by PET MRI, and because it was so equivocal on the conventional MR. Another case, very beautifully. Now you might think what's going on and whether this is, maybe somebody will say it's mesial temporal sclerosis, for instance. Okay, if I see it for the first time, I can see that there is something abnormal on the right side here and here on the flare, but it's not mesial temporal sclerosis. It's autoimmune encephalitis. Why? Because mesial temporal sclerosis, I will have hypometabolism, not hypermetabolism. Remember, as I showed you in the epilepsy cases. So this is a very nice way to distinguish mesial temporal sclerosis with hypometabolism, while autoimmune encephalitis, you have hypermetabolism, and also the other side is affected, but to a lesser extent. So in conclusion, I wanted to make this finish at exactly 10 o'clock. So in conclusion, the main biggies now are brain tumors, epilepsy, neurodegenerative disorders, but cerebrovascular disease, MS, and encephalitis, although there is still minor role for PET MR, but it is going forward and is very rich place for research. And so I hope in this review, I have shown you these values of PET MRI in various neurological applications. And I thank you very much. And the floor is open for any questions.
Thank you, Professor Dr. Yasser Abdelazim, for this comprehensive and innovative presentation about this new machine and its application. If anybody is having questions, please just write it in the chat box, and Dr. Doha will collect the question and will handle to Dr. Yasser. I will start with a couple of questions. You remember that we used to do perfusion and functional MRI to study different types of dementia, and default mode also of functional MRI will help us. So you think that PET MRI will replace this, or there is a still place for functional MRI in these cases?
Right. Okay. Very, very nice and good question. Now, when we did function MR, we always starting by doing a high-end conventional MR protocol for these cases. So the conventional MR protocol remains, we always do it with our PET MR cases. It's a must. We do it, and we do also the arterial spin labeling, which is non-contrast perfusion, and we do the PET. Now the issue is that whether we can also have resting state function MRI, we can, of course. It will take another extra 15 minutes, but it will take somewhat more money from the patient, okay? So it will increase our confidence in the diagnosis, because also by resting fMRI, there is a certain characteristic pattern on a functional level, not on a metabolic level, mainly that the default mode network, which is the main network of resting MRI, is reduced. All the components are reduced, and while the salience network has hyper activity. And remember that the default mode network, if we want to cross correlate them, the default mode network has the posterior component of it is what? Is the posterior cingulum and the precuneus, which is exactly what is hypometabolic with the PET, and the anterior components are cross coinciding with the temporal lobes. So actually, what the resting state fMRI says to us, that there is reduced activity in these parts of default mode network, is exactly what the PET MR tells us. And so having this confirmation and coincidence makes us more confident. But if for practical purposes, I would do this on 2 different sessions, okay? Because it will be a lengthy exam for the patient in 1 session.
In the same context also, in MS, now there is a very important issue. Everybody's interested in detecting brain atrophy. And you remember that we tried to use different techniques and different volumetric measurements like NeuroQuant or Sienna and so on. So with this PET MRI, you think, because it's very important for decision-making, especially in early cases, that we pick up that those patients, despite that they are not having any clinical problems, but they are having, starting to have cognitive decline and starting brain atrophy. So you think PET MRI can help also in this respect?
Okay, well, PET MR can help with the metabolic aspect of the disease. Like I said, that the white matter, the plaques, the normal appearing white matter in particular, which you cannot pick up on conventional studies, but you pick it up on the PET study, because it will not take the tracer, the amyloid, especially the amyloid tracer, okay? Now, if we move to the volumetric aspect, this is more for the cortex and the gray matter, etc., and deals more with the cognitive part of the disease. And this is, we are doing volumetry for our cases, certainly for MS. However, it depends on the level you want. NeuroQuant has been recognized and certified by a lot of people, and even in the conference, even in the American Society of Neurology conference, Dave Newsom, who is one of the leaders and epic names in neuroradiology, showed a slide in this domain exactly, showing NeuroQuant application and how you can triage the patients and put them into categories. So certainly this can be also done, because the data that we collect, which is T1 3D, it's a must to do T1 3D for PET. So you have the T1 3D raw data, and then you can use it to get the volumetric studies. You will not do anything extra. It's just a matter of having the software. We are using a somewhat another software, but NeuroQuant, of course, is the preferable one.
Dr. Hani, you are on mute. Can you please unmute yourself?
But don't you think that using PET MRI with FDG can help us in detecting the hypometabolism which might occur early in those cases and which is not detected by atrophy and only reflected by early cognitive impairment, which is very important in early cases in the multiple sclerosis?
Yes, this is a very good point because as I've shown, the eye cortex and the Z-score map can, even if I'm not seeing this early atrophy very well, because as you know, Dr. Hani, detecting early atrophy in MS cases is harder than in these neurodegenerative or dementia cases. Neurodegenerative and dementia cases, the atrophy is usually more obvious, but in MS cases, especially the early ones where you really want to detect them, I'm not speaking about the grave end ones, no, but the early cases. So if I find something suspicious, we do the eye cortex and we get the Z-score and we see whether the metabolism is there or not. Let me just go back to this slide quickly, and then you can see that we can do this quantitatively. But of course, like this slide, for instance, here. You measure the activity in all brain regions, and actually this is synonym to the neuroquant. It has the same like parietal, inferior, occipital, lateral, temporal, lateral, etc. So you do this, and you can also have a Z-score which can tell you that you have a low metabolism in one part, which you might not be seeing on conventional study or not. So you pick it up here by the hypometabolism. So the short answer to your question, yes, it can be used for this purpose, but better to be also confirmed by the neuroquant, which does the exact volumetry.
My last point before handling the mic to Dr. Doha to get other questions is regarding the stroke, especially in many cases, we are having the problem of stenotic lesions in the carotids and the vertebral arteries, and also intracranial stenosis, which you know is very common in Egypt. And you don't know whether this is having a great impact on the brain or not for intervention. And you know, of course, we are using the comprehensive stroke protocol in many of those cases with to get the perfusion in this region and to know the impact of the stenosis on the perfusion in the different regions of the brain. So you think PET MRI also can replace or can make addition to the perfusion study to select those cases who are severely affected by these stenotic lesions, or probably these stenotic lesions are not affecting the brain to that great extent?
Yes, very, very good point and very good question. Now, I think, as I showed, that PET MR can function in two ways. The first is to assess the plaque itself in the carotid artery or the vertebrobasilar system and confirm or even say whether it's a vulnerable plaque or not, because remember, with vessel wall imaging, we do not have this extra entity of the metabolism or inflammation. With vessel wall imaging, we are looking at the irregular margin, the hemorrhage, the fat, etc. With PET, we also look whether there is a high uptake denoting inflammation. So we can better say that it's a vulnerable plaque and take care of it. This is on one level, on the level of the vessel. Now, on the level of the brain parenchyma itself, we do two perfusion methods, arterial spleen labeling non-contrast and T2 star perfusion post-contrast. Now, I think, as you said, that the PET data, if it comes into the arena, can be an additive way to look at the metabolism of the brain in these areas. And if you pick up any hypometabolism in one part, then you know that there is this stenosis is actually a significant one. It's already causing hypoperfusion of this part of the brain. Yes. And so this can be also done by PET. So I think two functions now for PET in one study in these difficult cases you're talking about, where you want to triage the patient. Is his stenosis a significant one which is affecting his brain parenchyma now or not.
Exactly. Now I will handle the mic to Dr. Doha to get other questions from the participants. So please go ahead, Dr. Doha.
Thank you, Dr. Hani. We have a lot of questions on the chat. The first question we received from Dr. Hussein Farghali saying, are the findings in Fdg PET MRI specific for autoimmune encephalitis?
More or less, yes, because remember, it's a difficult disease to diagnose and difficult disease to image. And there is a lot of differential. If you go to the differential of autoimmune encephalitis, you will find paraneoplastic syndrome and limbic encephalitis and mesial temporal sclerosis and herpes simplex, all these issues together. So if you have something that pinpoints to the disease like PET MR, I think it is really helpful. And as I showed you the case, you can make a differentiation between autoimmune encephalitis and mesial temporal sclerosis. So I think this is an important addition in making this particular diagnosis.
Great. We have a question, a comment, not a question, from Dr. Muhammad Bayoumi saying, with highly thanks, I recommend to be sure about the QC for the PET MRI, especially with accuracy of the image registration and ACR phantom to make sure, or to be sure about the image quality. This was just a comment. Yes. We have a question from Dr. A. Ashur, thanking you, Professor Dr. Yasser, and then asking about the type of tracers available for dementia in Egypt and Ain Shams University in specific, in particular in the context of research, as the diagnosis worldwide is based on clinical findings, PET findings, and autopsy findings, which is not applicable in Egypt.
The PET MR machine, the PET MR machine is not present in the university hospital. It's in another place that we mentioned at the beginning, and the tracers now that we have now the PET, the Fdg tracer for now, but we are really seeking to get, and we have been promised by the company to get the amyloid plaque tracer. And I can tell you that the tau tracer, which is the third one, even in USA, it's still a way to go for it, only in few research centers. I've been to Stanford last year and saw some applications of tau tracer. But so to answer your question, Fdg we have and we work with it. Amyloid plaque is coming in the arena for neurodegenerative and dementia cases, and also we can use it for multiple sclerosis cases. Tau tracer in the not so far future, I hope.
Can I, because I also adding to this question, you think it will be more, the price of the tracer will differ from one to another, or it's more or less the same?
We hope to not be more expensive, but with our experience, PSMA is certainly more expensive than Fdg, but not that much, you know. So this and always this depends on how many patients that you can do. So why Fdg is the cheapest tracer in Egypt? Because there are so many PET CTs done using it all over the country. But PSMA is only done in a few centers for prostate in particular, which makes the company, in order to produce it, it takes from them a lot of money to produce this, okay? So the more cases you have, the cheaper the tracer becomes.
Okay, thank you, Dr. Yasser and Dr. Hani. A question from Dr. Muhammad Assam. Is there any role of PET in metabolic encephalitis, like Wernicke encephalopathy, for example?
Yeah, for Wernicke's encephalopathy, I think that all these other diseases, besides what I mentioned for you, now let's make it like this. In USA in the highest centers, in Europe, especially in Germany, in the highest centers. What I told you, which are brain tumors, especially residual versus recurrence and grading, epilepsy, especially for detecting the epileptic focus when the conventional high-end MR is negative, and preparation for epilepsy surgery, and neurocognitive disorders. These are the main 3 big PET-MR neuro applications. Now for minor applications, if you Google, you will find everything some people have tried for it, you know? So depends on the case, whether this would have a hypometabolism or hypermetabolism and the purpose of your assessment, okay? So this will be more minor applications. And the other issue is that when you go into these more metabolic or toxic or whatever types of diseases, you always find that people can start talking to you about specific tracers, not the FDG. Because FDG, as you know, is uptaken by normal brain tissue more or less. So now you will go more to specific tracers, which are expensive and might not be available to everybody, even in the West. So these things usually fall under the research and grant domain.
Okay, thank you, Dr. Yasser. We have a question from Dr. Passant. Can PET MRI differentiate between autoimmune encephalitis and other types of encephalitis as bacterial or viral?
Well, the short answer is that I would think that bacterial and viral in the acute stage will also have a hypermetabolic uptake. However, what I can tell you is that, as the case I showed you, all of the encephalitis will have a hypermetabolic uptake, especially if there is disease activity, but you would now look for the location. So as I showed, if it is hippocampal, perihypocampal location and temporal and etc., it will be more going with autoimmune encephalitis or herpes, while in other locations, it will be with other types of encephalitis. So first of all, you will confirm that you have something wrong in the encephalitis domain, and then you would look where are the most affected areas and look for them. Exactly, Dr. Passant, like the neurocognitive disorders and dementias. Now you have the patient has dementia or has neurocognitive impairment. So your task becomes that, and he has brain atrophy. Okay, your task becomes, what is the type? So what's the type? You look at the pattern and the fingerprint of the disease. I hope this is quite clear for you.
May I also extend this question because we are in many situations, it's very difficult to differentiate between herpetic encephalitis and autoimmune encephalitis, and to the extent sometimes even the CSF is normal, and of course the lab study for the autoimmune encephalitis is quite expensive, and sometimes we are having rare types which is not even routine in this lab workup. So you think that the addition of PET MRI can easily differentiate between herpetic encephalitis and autoimmune encephalitis?
Really, I don't have a frank answer on top of my head now, but I am sure that this is a very interesting topic for research. So I think this is has to be tried and researched upon. Where there must be a group of patients, then you can prove that they are herpetic, and the other group you prove they are autoimmune, and then start to look at the different PET uptake patterns in both groups. Okay, but for me now it's difficult because I would imagine both of them will have hypermetabolic activity, bilateral asymmetrical. Maybe I can tell you maybe that autoimmune will have a more symmetrical bilateral pattern than herpetic, but this is one of the differentiating points because herpetic usually asymmetrical. Yet I am sure that when the more cases you do, the more you start to triage them. Exactly like the dementia cases where they found, because they did a lot of cases of dementia, so they started triaging them into Alzheimer, frontotemporal lobar, and dementia with Lewy bodies, and even corticobasal. I didn't talk about it, but in order to make, not to make this very lengthy, but also corticobasal has a certain pattern.
Okay.
Question from someone registered under his phone, so I don't have the name. He's asking if the PET is asked, is convention MRI is done as well with the PET MRI exam? And he's asking, by comparison, how can we decide if one of the sides is hypometabolic and the other is hypermetabolic?
Okay, so let me show you this slide. Of course, for the first issue, all the PET MR is combined with a high-end, high-quality MR done on 3 Tesla. Because remember, all PET MR machines have a 3 Tesla MR. So you are getting high-quality MRI using 3 Tesla for all the studies. And even we do everything we can. We do non-contrast perfusion, contrast perfusion, diffusion, spectral, everything that we can throw in, we throw. We are, you know, our limit is that we don't want the patient to be tired, you know, so, but we are ready to do everything. So the answer is that he gets a high quality MR besides the PET MR. For the hyper and hypometabolism, I think this slide shows very well. Look at the normal metabolic uptake here. In this case of frontotemporal dementia, this is normal, having high Fdg uptake, and this is hypometabolic anteriorly here. And if we want to see the abnormal hypermetabolism, I can see the encephalitis case, like here. The encephalitis case, you can see this is hypermetabolism compared to the normal metabolism on the other side and of the cortex, okay? And of course, this is by eyeballing, but we have SUV measures, and SUV is measured according to the liver or according to the blood pool, and also we have these Z-scores I mentioned. So not only we do not only rely on qualitative assessment, but quantitative assessment as well. Quantitative assessment is also very, very important in our oncology cases, because you want to have these measures in order to follow up the patient after that. Whether he has successful therapy, you will get drop of the SUV measures or vice versa.
Thank you, Dr. Yasser. I'll announce 3 small questions. Dr. Toti is asking, please, what's the meaning of hybrid imaging? I think this has been answered. And then another question asking about the study of the dementia. What's the cost of the study of the dementia? And if there's any specific preparations for the PET?
Okay, and now let me start by the last thing. The specific preparation for the PET are many. I cannot list them here, but we give them to every patient, and including fasting and controlling his blood glucose and having a good creatine level, all these things. There is a brochure given to all PET-CT and PET-MR patients, and he's most welcome. You can send it to him if you like. You can tell him the email that he can give us his email, and we will be sure to send it to him. Now, this is for the preparation. The other thing was the cost. Well, the cost is for now we are charging 12,000 for the FDG cases and 15,000 for the PSMA or DOTA-TET cases. So whatever is the indication. So if he's getting FDG, whether for brain tumor, epilepsy, or dementia, it's 12,000. If he is getting PSMA, it will be 15,000. For the amyloid plaque, I don't have a price now because it will depend on that situation, how much the company will sell it to us. Is there another thing he was asking about?
The third one was just asking about what's the meaning of hybrid imaging, if you'd like to elaborate.
Hybrid is better than fusion. Hybrid means that when you take 2 things and make them one exam. So when you say PET MR, this is true hybrid when, as I showed you in the machine, let me go back to the machine, that the patient has simultaneously having PET and MR together, okay? So now you get hybrid imaging because the data was acquired at the same time together. But some people used to do what they call fusion imaging. They will do a MR in one machine and then do PET-CT in another machine and then put them together and say this is PET-MR, this is not PET-MR, this is pseudo-PET-MR or fused images together. But here in this machine, you have the PET tracers inside, the PET, I mean detectors, PET detectors inside the machine, and you have the coils for the MR and everything to do an MR in one machine. So he's done simultaneously, and that's what we mean by a hybrid technique. And you can see that it's called PET MR. It's not PET CT, and then you do MR, and then you put them together and tell the people, I did PET MR, okay?
Thank you, Dr. Yasser. Dr. Ramez Mustafa was asking if there is F-DOPA for Parkinson's, and could this be made available in the future? I think I can answer this. I know that our nuclear department is already planning on this and working on it, and hopefully it will be soon available. Do you like to mention any additional comment, Dr. Yasser, on this?
Yes, I think we need F-DOPA, and I brought this slide because it can be also used in Parkinson and also in brain tumors. So we certainly need it. There are a whole host of tracers that can be done with it. And as I said, the problem is the availability of how many patients. If you get us the more patients you send us, the more we can get these more specific tracers.
I guess this would be also badly needed because we need, of course, F-DOPA to, we are having a lot of cases of Parkinson, and sometimes we are not sure whether this is a classic Parkinson disease or atypical Parkinsonism or other types like other types of Parkinsonism. So I guess this is very important to be available.
Yes, I had this part in my talk, but because it is all about a tracer that we don't have, so I didn't want to go through it, but this really depends on having this tracer, these specific tracers, and all the PET MR facilities I went to, and also Dr. Yahya Omar Hussein, who's done a whole lot of PET CT and has a very wide experience, you do not find in any one place all the tracers, okay? So every department we go to in the West, they are specialized in maybe 3 or 4 things. FDG, of course, is available for everything, okay, whether PET CT or PET MR, but they will choose maybe 2 or 3 things where they have lots of patients coming to them. So for instance, a center might be more specialized in prostate cancer. So they will have a lot of PSMA cases and even other prostate tracers, not only PSMA. And another place which will be more having dementia and neurodegenerative cases. And another, so nobody can have everything of this, so you will have to work with us. The more cases you send us, we promise to get you the tracer.
Okay.
Hopefully, inshallah. This is the last question that we have. Is there any contraindication for the test?
No contraindication for the PET MR except the known contraindications for MRI, but nothing for the PET itself. So no new contraindications. The contraindications of the MRI, which we all know, which are now getting very, very limited, like aneurysmal clips, old metallic devices, pacemakers, cochlear implants, stuff like this. But all recent surgeries have been now done by non-ferromagnetic instruments and objects, etc. So it's the list is really very limited of the contraindications. And but if I may take this a further step, PET-MR has a very important advantage. You do not use ionizing radiation, so it's very suitable for children and for people who don't want ionizing radiation, and for follow-up cases that have many follow-ups. So it's very well suited because there is no ionizing radiation.
Thank you, Dr. Yasser. This was the last question that I have. If anyone has any other question or concern or thought that they would like to share, please feel free now.
If I may, I think I wanted to redo this case again because I got somewhat confused with it. Now remember that the case after it, this was a true recurrent viable high-grade tumor tissue with the high uptake in the PET here corresponding to the enhancement, the hyperperfusion kit. But I think I might said wrong information in this case. This was actually post-treatment changes. There is enhancement, but there is no hypermetabolic status. There is lack of any hypermetabolic status. So this was actually post-treatment changes, although there is enhancement, unlike the other one where there is viable tumor tissue, and unlike our PSMA case, which we spent some time on it, where we have true hypermetabolic status. So this is just to make my conscience clear. Okay.
Thank you, Dr. Yasser, for elaborating.
Okay, so I hope all of you enjoyed it, and we have recorded this session, and we are going to send it to you and for those who couldn't attend it. So any closing remarks from Dr. Hani Arif for?
I thank you, of course, for this very comprehensive presentation about this new innovative technique. And I guess this will open the door for of course, for referrals and also for research, because it's very unique machine, and possibly we can work on a lot of things, especially that we have already shared some new ideas about different diseases, and I hope this will come true in the near future.
And I promise you that for research we have different prices.
Okay.
Because we get a collection of cases, like if I want to say in Arabic, like difference between Atai and Gomla.
Okay, we will work for grants actually, because we are trying to work for research grants now, and I guess this is the only solution for this.
So if you get a grant, then we will go back to Atai.
Okay.
Okay.
Thank you.
Thank you everyone for attending. Thank you so much, Dr. Hani Arif. We really appreciate giving us the space and floor for this. Thank you so much, Dr. Yasser Abdelazim, for this amazing presentation. And thank you all the colleagues and professors for attending. Of course, the discussion doesn't stop here. Please feel free to reach out to us on the email mentioned in the chat. It's medical_info@misrradiologycenter.com. We of course, we're pleasure to answer any question or any thought that you may have. And of course, I'll make sure I connect you to Dr. Yasser. And of course, we'd love to have you and pay us a visit in our new branch at New Cairo anytime to see the machine working and everything. Thank you all for attending.
Bye-bye.
Thank you. Assalamu alaikum.
Salam.